Every morning, millions of people twist a bottle cap the wrong way, push down while turning, then try again. Some give up and ask someone nearby for help. It is a small daily frustration so normalized that most people never stop to wonder why the cap was designed to resist them. The answer begins not with a designer trying to be clever, but with a problem that was killing children at a rate that no one in authority could ignore. For most of the 20th century, medicine bottles closed with a simple friction cap. You pressed it on, you pulled it off. A 2-year-old with enough curiosity and 15 seconds of privacy could do exactly the same thing. Aspirin, iron supplements, sleeping pills, and prescription medications sat in bathroom cabinets behind nothing more than a cap that offered about as much resistance as a jar of peanut butter. The assumption built into that design was that adults controlled access. The reality, documented in emergency rooms across the country, was that children found ways in with alarming regularity. The underlying constraint was a paradox that no one had formally named yet. A package had to be easy enough for an adult with arthritis or poor hand strength to open without a tool, and simultaneously difficult enough that a healthy, determined small child could not open it at all. Those two requirements pull against each other. Make the cap loose and easy, and the child wins. Make it tight and complicated, and you shut out the elderly patient who needs the medication most. Solving one side of that equation had always seemed to break the other. The regulatory response that forced a real solution came in the form of legislation. In the United States, the Poison Prevention Packaging Act was signed into law in 1970. It required that certain household substances and medications be sold in packaging that was significantly difficult for children under 5 to open while remaining usable by adults. That law did not specify exactly what the mechanism had to be. What it specified was a performance standard, and it created the test protocol that gave the standard teeth. The test itself is the part of this story that most people have never heard about, and it is the mechanism that actually changed everything. The protocol requires that child-resistant packaging be evaluated against 2 distinct panels of human test subjects. The first panel is children between the ages of 42 and 51 months, roughly 3.5 to 4.25 years old. A defined percentage of that panel must fail to open the package within a set time limit, both with and without a demonstration of how it works. The second panel is adults, specifically adults who may have reduced hand strength or dexterity. A defined percentage of that group must be able to open the same package successfully. That 2-panel structure is not a formality. It is the core engineering constraint translated into a live human measurement. Every candidate design has to thread the needle between those 2 populations simultaneously. A mechanism that stumps children but also stumps older adults fails the test just as definitively as one that children can crack open in seconds. The cap that eventually became standard, requiring the user to push down while simultaneously rotating, worked because it exploited a difference in cognitive and physical coordination between young children and adults. Small children tend to apply force in one direction at a time. The push and turn combination requires coordinating 2 simultaneous opposing movements, which is genuinely harder for most children under 5, even when they have seen the motion demonstrated. Adults, having years of practiced fine motor coordination, can usually manage it within seconds once they understand the mechanism. The adoption of this standard did not happen without resistance. Manufacturers initially worried about consumer complaints from adults who found the caps inconvenient. Pharmacists raised concerns about dispensing efficiency. There was a real commercial tension between safety compliance and the ease of use that retailers and customers expected from a product. What tipped the argument was not goodwill, but documented consequence. The legislation existed because the poisoning data was undeniable, and companies that distributed medications and household chemicals did not have the option of treating the standard as voluntary once the law was in force. The packaging requirement extended over time beyond prescription medications to cover over-the-counter drugs, iron-containing supplements, and certain household chemicals and pesticides. In some jurisdictions, unit packaging such as blister packs also came under child safety regulation, because even without a single opening, a child could potentially access individual doses. The expansion of coverage reflected a growing understanding that the hazard was not limited to bottles with traditional closures. Any package containing a substance that could harm a child in small quantities was a candidate for the standard. The design also acknowledged a deliberate exception. Manufacturers are permitted to provide packaging without child-resistant features when a patient or customer specifically requests it. This matters because the population most likely to struggle with push-and-turn caps includes elderly patients on multiple medications who need daily access without the physical difficulty the standard cap imposes. A blanket requirement with no opt-out would have created genuine harm of a different kind, trading one population's risk against another's. The exception preserves individual judgment while keeping the default on the side of protection. There is an honest uncertainty worth naming here. Measuring the effect of child-resistant packaging in isolation from all other interventions is genuinely difficult. Public education campaigns, changes in how medications are stored, improvements in poison control infrastructure, and the packaging standard all moved together across the same decades. Attributing reduction in childhood poisoning incidents to any single factor requires careful statistical separation that is not straightforward. What the evidence supports is that child-resistant packaging became a standard component of a broader safety system, and that the system as a whole produced measurable change in outcomes. Today, the push-and-turn cap is so embedded in daily life that the frustration of opening it has become the cultural default. People joke about it. Grandparents ask grandchildren to open their medications for them. The difficulty is so familiar that it reads as a design flaw rather than an intentional engineering feature. That familiarity is actually the signal that the design succeeded in one of its core objectives. A safety mechanism that became invisible background noise, accepted without examination, is one that got adopted at scale. What the child-resistant cap reveals about design more broadly is the discipline required to hold two conflicting requirements in view simultaneously and refuse to solve only one of them. The push-and-turn mechanism is not elegant in the way a precision instrument is elegant. It is a compromise, arrived at through a human-tested performance standard rather than through a single designer's inspiration. The legislation created the constraint, the test protocol operationalized it, and the mechanism that survived both was the one that threaded the needle between a 4-year-old's coordination and an elderly adult's grip strength. The lesson the cap carries into adjacent problems is not that safety and usability are permanently opposed. It is that you cannot resolve the tension between them by optimizing for one population in isolation. The two-panel test forced engineers to hold both users in the room at the same time. That structural requirement, written into regulation rather than left to voluntary best practice, is what produced a design that actually worked across the real population it was meant to serve. Every object that asks something from a user while protecting another user from a different risk inherits a version of that same problem. The child-resistant cap is the version that got formalized first. Visual reconstructions are illustrative. Facts and interpretations are based on the sources listed in the description.